Hi, Dr. Donald Jervich from the University of North Dakota. Today we have a presentation on the geriatric 4Ms. This is part 2 of the 4M construct of mind, and we're going to focus on depression. The goals today are to look at depression assessment, as well as management when there's screen negative for depression, and then management when depression screen is positive. Again, always linking each of these 4Ms into a action plan, whether they're screen negative or positive. So as a reminder, this is part of the Dakota Geriatrics program. It's a HRSA-funded program to try to strengthen older adult healthcare with evidence-based medicine. So we know that depression screening has a variety of tools. There's several dozen of them that are available to various forms. I think most healthcare systems have migrated towards the personal health questionnaire 2 and 9 because they're very rapid, they're portable, and they're commonly understood. Geriatric depression scale is also a possibility for use. It's a little bit longer. However, it does not query suicidal ideation. And then the Cornell Depression Scale has been around for quite a while and would be a niche type screening tool for individuals that have previous stroke. So that's the value of that particular screening tool. So just to do a quick dive here, the patient health questionnaire asks 2 questions, and you can see how they're rated on the scale. Bottom line is that a score of 3 or greater would be suggestive of depression. And so the next step would be to go to the PHQ-9, and this helps score depressive symptoms and puts it on a scale. Again, so it's a staging tool, and we know that we can use it repetitively, and that if a individual has a score of 5 or greater, that it requires an action plan. So either a medication adjustment or the addition of cognitive behavioral therapy and other interventions that we'll talk about. So the screening with the PHQ-9, the advantage of it is that it covers the major criteria for depressive disorder. Certainly those who acknowledge thinking that they would be better off dead or hurting themselves should be asked about firearms or weapons in the home, and to make sure that I guess I would add that both the caregiver or spouse, for example, as to whether they have weapons also, because a lot of times couples will hunt together, and they may have separate gun lockers or stashes of hunting weapons that, just because one is secure doesn't mean necessarily that the other one is secure. And then you want to use the PHQ-9 for serial administrations to get an understanding of how well the therapeutic plan is working. And I just add this Cornell scale for depression. It's like I say, it's more geared for individuals with neurodegenerative complications such as stroke and dementia. And then the geriatric depression scale, just a quick synopsis of that. It's a 15-point item. You just simply answer yes or no. Again, the wrap on that is that it doesn't have the suicidal ideation questions, and it really is not useful for tracking. So again, it's available. It's a good construct, but like I say, I think if we stick to the PHQ-2 and 9, we'll be doing quite well. So If the depression screen is negative, it reminds us to refer back to what matters and to identify what is the life mission for the individual and what their goals are. I often find that when I ask, what do you do when you wake up in the morning? What is your day like? And if I eat breakfast and that's it, I become concerned that the individual's life mission is not fully either articulated or developed, and may be a harborer of either early dementia or depression. So the risk for depression in the older adult population are typically people who are sedentary, obese, and alcohol misuse, and smokers. Also, there's been a connection with low vitamin D levels. It's a little bit controversial. Certainly traumatic brain injury. And probably most importantly for us to consider is the caregiver status, because if you have to care for a loved one, that is a high predisposition to depression. So here's a score sheet, if you wish, as to what the clinical response should be if you have moderate to severe depression. And the bottom line is to consider an antidepressant very early on in the process of identifying somebody who is depressed. I would add that the combination of cognitive behavioral therapy with an antidepressant is synergistic and has a much better response than either one alone. So how's geriatric depression different than other adult populations? The older adult sometimes is more preoccupied with somatic symptoms, and they just won't always report that they're depressed. So the other element of this is to consider anhedonia as a diagnostic criterion for a major depressive disorder, as opposed to somebody admitting to sadness. So again, that kind of listlessness and not doing much of anything. So part of the problem with understanding depression in late life is that there's a overlap with chronic disease and the somatic symptoms that are associated with multiple chronic conditions. There's actually a diagnostic category of mood disorder due to general medical condition. And so that's something that we might consider as we identify people with depressive symptoms with 3 or more chronic conditions. Just want to, excuse me, emphasize the aggressiveness of treatment that is beneficial and evidence-based for addressing depression. The current recommendations are to continue treatment for 6 months, and if the condition was severe, that we would want to maintain the therapy for at least 3 years. Just to emphasize that we want to add cognitive behavioral therapy to the intervention. Of course, psychiatric referral is always a possibility, and particularly important if there's a suicidal or homicidal ideation. We already mentioned about addressing firearms if the patient screens positive for harm to self or others. And there's multiple community resources that for mental health that could be used, and so always keep those in mind to supplement your medical intervention. Just want to mention that St. John's wort is as effective as an SSRI, and this comes up in clinical practice if somebody is not inclined to take a medication, but they might want to be consider, I should say, a herbal medicine. And just to point out that in Germany, the vast majority of patients with depression are treated with St. John's wort as opposed to SSRI, and there's multiple studies that show equivalency. The other talking point, if you will, for pharmacologic management of depression is that you would like to optimize the dose of the first agent before adding another. And a general axiom in geriatrics is to avoid the SNRIs, mainly because of the cardiovascular complications associated with those. So we know that there's a 50% response rate to depression with our interventions. And then of those who didn't respond, 1/3 of those will respond when you switch to another agent or add a second agent. And it's important to understand that just about half of those who recover will experience a reoccurrence. So again, it reemphasizes why we have to constantly be vigilant and screen for depression with each clinical encounter. In the first weeks of treatment, which is a milestone, so the first 4 weeks is a milestone that's very predictive of what's going to be the response at 12 weeks. And roughly it's broken up into thirds. So a third will be non-responders, a third will have responded partially, and then others will have fully responded. So it's important, and again, evidence-based, that a follow-up call be done within the first 7 to 10 days to make sure that the patient's firstly taking the medication and that they're taking the right dosage, and then have a call back at week 4 to identify those who are partial or non-responders. In terms of the antidepressants, the go-tos are the SSRIs. Again, there are the SNRIs available, but to be not on the first line of treatment. And then the tricyclic antidepressants, which tend not to be the first line of treatment these days. Just a few here. I mean, there's others that are, these are mildly activating SSRIs. And so the so-called Celexa or Lexapro. Sertraline is good. I would just give a caveat that it's a little more sluggish in activation, and whereas Lexapro and Celexa are within a week, you should get a response if you're going to get a response. So that's my understanding of those comparisons. Trazodone and mirtazapine tend to be good choices also if an individual is having sleep problems, although I will say that the evidence is not strong, it's more anecdotal, that both of those agents are sleep-inducing or sleep-assisting medications. As per our previous presentation, we found that hyponatremia can occur in the older adult population, and you can see the prevalence there for the 2 examples from the literature. So the SNRI has a little higher tilt towards hyponatremia, and again, that's one of the many reasons why we try to avoid SSNRIs in the older adult population. So these medications are not without side effects. There's an increased odds ratio for falls and fractures. So in some cases, it becomes a necessary evil. But again, getting to the 4 M's of addressing mobility and fall risk, all should go hand in hand. So you can see how the 4 M's intertwine with each other. Just a brief mention about serotonin syndrome. I don't want to spend too much time on this. And then just to summarize that if you have a screen negative for depression, to please promote social wellness. Sometimes people will say, oh, I used to go play cards with a group, but I don't anymore, or I used to go to church, but I don't anymore. Those are soft indicators that there might be some mental health issues going on, either from depression or social isolation or dementia. And then the screen positive, I think we have a sense of where we go from there. We firstly had screen positive through the PHQ-2. We then migrate to the PHQ-9, and then we consider, based upon that score, cognitive behavioral therapy, medication therapy, firearms review, and then also to consider underlying dementia, with the caveat that people with depression will have memory loss, and so you can't really ascertain whether they have dementia until they've been fully treated with the depression. Just a final summary that depression is common. Be very mindful of whether it's grief or unresolved grief versus depression. Usually we use 3 months as a cutoff. People will always have grief throughout their life. There's no such thing as resolution at a particular date, but we just need to be mindful of the vegetative symptoms that might accompany unresolved grief. Already mentioned that depression may be the first sign of dementia. Quick screening with PHQ-2 and follow up with PHQ-9 if positive. And then always be mindful of non-pharmacologic interventions such as cognitive behavioral therapy, which will synergize with our medication therapy. And I didn't add to this, but just as a reminder that St. John wort is equivalent to SSRIs for the impact or management of depression in older adults. So thank you for your attention, and I look forward to your practicing the geriatric 4Ms.